last 2 3 years. Now, personally, I feel that in my personal practice, I have started using in most of my patients. Although the indications, as you say, are only limited NAV patients, those who do not have any history of Cangrelor or clopidogrel. But personally, I feel that we are doing complex angioplasties, and when you are really wanting not to have any complication, and you are not sure of the clopidogrel, especially clopidogrel resistance patient. So, do we think that, especially it's a harmless drug, does not cause major bleeding? Do you think that other than patients, in all patients, especially those who have earlier angioplasties done and who are supposedly continuing on clopidogrel, there is no harm, I personally feel, in using this intravenous dosage while you are contemplating PCI for a new stent or something. This is one thing which I personally feel. You have another reason to say something, then you are free to say Dr. Chavirana. Another thing which I wanted to highlight about this molecule is that intravenous, how long do we really go for the infusion, number one, before you transiting it? And secondly, GB, do you have, if you are using Cangrelor, do we still have the space to use GP2B3 receptor antagonist, especially when you're using long stents or complex PCI or bifurcation? This is a question to Dr. Manoj.
Yeah, glycoprotein 2B3 inhibitors are irreversible inhibitors, but having said that, the tyrosine is partially reversible. And when you use that, the molecule, the 2B3A is the last pathway of aggregating the platelets or adhesing the platelets to each other is already attained, and therefore the role of short-acting and reversible Cangrelor does not exist. In fact, combining that could add to more bleeding instances. 2B3A inhibitors distinctly have a high risk of bleeding, and we have seen many patients with the gingival bleed, which is very common, and GA bleed is very common, groin or axis.
That means the role of GP2B is almost gone once you are using Cangrelor?
I have not been using GP2B inhibitors in the last 10 years or more.
You're not, okay. Otherwise, that means if you're using Cangrelor, there is no need to use a GP2B receptor therapy. Can we conclude on that, Javed? You think? Because GP2B3 receptor antagonists still have a role, and we have a lot of trials as such. You may not be using it, but a lot of centers are using it. If we are having Cangrelor, there is no need to use GP2B, or still in complex PCI bifurcation left main, something like that. Would you like to have another antiplatelet continuing?
If we anticipate the use of the GP1, the glycoprotein 2B3 receptor antagonist, we may not use Cangrelor. But as Manoj said, our use of glycoprotein 2B3 receptor antagonists have come down like hardly 2 vials a month. Only after angioplasty or after a primary angioplasty, there is a significant slow flow which is not improving. Or we feel that mostly because of a slow flow post PCI, it is not improving, where we are using GP2B3 receptor antagonists. But as you said, right now I am using Cangrelor if possible for all primary PCI, but not for an elective PCI. And as the selected indications, like whether it's an administration problem, patient cannot swallow, patient cannot take the drug, he's on ventilator, he's in cardiac shock, and excellent cases which were shown by Manoj. Patient is critically ill, we are not in a position to start on an oral agent, and we need a very potent antiplatelet agent on board when we do the angioplasty. And it is it's a lifesaver at that time.
Any question from the other panelists? Okay, any comment from the, yes, you can go ahead. Yeah.
Sir, usually we don't get NAVE, antiplatelet, DAPT NAVE patients for SES. And most of the times, a GP or a physician has given 300 clopidogrel. And the patient comes in time within an hour or so. Then in those cases, is there any modification required for the protocol of giving Cangrelor? Because there are obvious benefits.
If it is clopidogrel, I will have no reservation in starting Cangrelor, because Cangrelor is very predictive. There is no inter-individual variability. We always know that there is a distinct inter-individual variability and poor resistance for clopidogrel. If the patient has received Cangrelor and it's distinctly documented, many times they may not have documented. So if you're not certain about the loading doses and the STEMI is still there, and the patient says that some medications were given, could be just an aspirin alone would have been given in many instances. If it is not properly documented, you are not certain as a primary operator for PCR, you would certainly use Cangrelor. But if patient is on receivable clopidogrel, I would definitely go ahead with the IV Cangrelor bolus and infusion, and then transition to Cangrelor.
So whatever antiplatelet the patient has received earlier, may it be clopidogrel, may it be ticagrelor, this Cangrelor can be used in the same protocol.
Of course, yes, yes.
Receive a Cangrelor, and you're certain, definitely certain, and 1 hour has elapsed, I don't think I would give it.
So if he is given ticagrelor, then 1 hour is gone, then you don't need Cangrelor. That's what
You
you
do not
want.
need it.
Okay.
Most of the instances, there are directly patients reporting to the ER without any referral in the interim period on the travel. So they come to the ER directly, and you find a STEMI, and you're just loaded, but you might take him up directly to the OT or a cath lab for your PCI. So by the time you have a patient on the table, at least in our center, the patient is on the table within 15 minutes of arriving in the ER. So that is the kind of protocol that we put in place. So within 15 minutes, the patient is on the table, angiogram is performed. By 25-30 minutes, the patient is angiogram is conducted from the time he is reported to the ER. So if you stop the PCI, there will still be inadequate platelet infusions. And there are many instances that patient would be vomiting and given 2 loading doses of ticagrelor, and both times the patient vomited. So I was not sure whether the drug is actually absorbed or not.
If in a situation where we have loaded with ticagrelor, 1 hour has gone, but once we do the angiogram, there is a lot of thrombus there. Should we still use Cangrelor?
There is a high thrombus load you can certainly use because it is definitely useful. As I said, as David said, even many instances of slow flow, I use post-PCI, IV Cangrelor, bolus and infusion for at least 12 hours.
So because that in many cases adequate antiplatelet inhibition may not be there for few hours.
Yeah,
Even with full dose ticagrelor.
bioavailability. The
Right.
patient may have ingested about 1 hour back, but still the bioavailability will be different.
So that's what I do in my practice. I just wanted to confirm, because while discussing the protocol, we discussed only platelet naive patients.
That's what I said, that there is no harm.
So
Sorry.
even if
Yeah, there is, continue, you can have another question. Yeah. There is no harm actually. If there is no harm, then why not we have 100% surety that you will have a good platelet inhibition while doing a acute coronary syndrome, mild thrombus, haze, thrombosis or something. In this question, I think there is no harm in using in most of the patients of PCI. Yeah, what?
In slow flow also, the Cangrelor uses distinctly reduces the bleeding, unlike the 2-3 inhibitors which have an extended effect and patient can have a high risk of bleeding.
So do you think that even if ticagrelor has taken its full effect, it has actually inhibited 90% of the platelets, 1 hour has elapsed, 1.5 hours has elapsed, and the absorption was really good. Still we give Cangrelor. The site of action is on the same P2Y12 receptors, but maybe the actual site may be a little bit different. So giving extra Cangrelor will not cause any harm, do you think so?
Certainly not, because it is, the offset is very, very faster. So even if the patient has any signs of bleed, you can stop it and the bleed will stop.
So I have one question for you. See, the real advantage of this Cangrelor is in the first 120 minutes or so. By 2 hours, anyways, ticagrelor effect would have kicked in. Most of the stent thrombosis will occur after you have finished the PCA after 2 hours. So the real problem in the first hour or the first 2 hours is no reflow. But have any of these trials have had a mention of secondary endpoints about no reflow? Or
This stent thrombosis is happening beyond the 2 hours. It's very likely to be due to age dissections or anything, which cannot be prevented by any antiplatelets. Because if there is a age flanked by the dissection, the age, and there is no flow, the same with thrombosis, because it's a stagnation there. So I have not had any such experiences where patient had age stent thrombosis. You are certain that the optimal PCI outcome is ensured on the Cangrelor itself. You see the flow. If you want, you can do an IRS also in certain imaging modalities can be utilized. And we are certain that the optimal PCI outcome is ensured the stenosis doesn't happen because of stent-related factors or procedure-related factors. Antiplatelet effects are certainly distinctly taken care by the bolus and the infusion of Cangrelor. But I would say that if patient has still poor gastric motility, given up to 48 hours infusion. But there are patients who have sometimes paralytic IBS and their gastric motility recovers later. So giving them nasogastric medications may not actually provide them with bioavailability.
Just I wanted to know that is there a comparison between the procedural success or the flow rate, no flow, TIMI 1, 2, 3 achieved in the Cangrelor versus no Cangrelor? And regarding this, the switch or the infusion which we do before the surgery, I think that Ticagrelor by 48 hours its effect is almost 70% lost. So is there a point in giving Cangrelor we can directly take after 48 hours?
Most of the emergency surgeries, especially left main or patient is crashing on the table, especially like Dr. Vivek was saying, complex PCI. You keep this on board and patient has a crash and wants to consider CABG, a surgical option, as a salvage surgery. And this is a molecule which will allow you to safely do the surgery without high risk of pain within 19 minutes of stopping.
Not like that, means your patient is not acute coronary syndrome patient. He has had a PTCS, suppose 3 months back, he is on Ticagrelor, and then the previous speaker I think had showed that after 48 hours of Ticagrelor or clopidogrel, you switch over to Cangrelor. But it is not about ACS, it was not mentioned about it. It is about switching over the infusion therapy to
for the other surgeries. The patient has had PCI,
yeah,
and then going for cardiac procedures,
and
you can bridge it. You can bridge. The bridging dose is 0.75 micrograms per kg.
But why Ticagrelor, the effect will be lost within 48 hours, almost 70% effect is lost. Why do we want to bridge it?
But still, many of the surgeons are not comfortable operating.
I think this is a very additional advantage. This is a big advantage actually. We are having surgeon Apollo. They want to wait for 2, 3 days, 4 days. So I think if the patient is, you are contemplating something like bypass surgery or non-cardiac surgery, especially bypass surgery, it's a very big advantage over oral antiplatelets. Dr. Natarajan, you want to say something? Yeah.
This is a comment. We have had a lot of experience in primary PCI. This is in reference to the extreme statement of the other that all of his primary PCI patients is coming back to substitute Cangrelor. Just to object to that particular extreme statement. He said that in all his primary PCI he will give Cangrelor. That's his current practice that he mentioned.
Dr. Vivek also mentions that actually.
This is what I'm saying. Yeah.
So I just wanted to ask you, we had a lot of experience in primary PCI without Cangrelor, with the pre-Cangrelor days. You are blocking it. So in the pre-Cangrelor days, we had immense experience with primary PCI, with Ticagrelor, in the conventional loading doses. How often have you really perceived the need for a straight case of slow flow that we used to give glycoprotein antibodies once in the past? So my question is an extreme statement to say that all primary PCI Cangrelor is scientifically justified in giving, or you do the usual way and you find some no reflow, etc. Instead of giving glycoprotein, is giving Cangrelor as a bailout strategy at that point in time. Is it more justified?
Certainly, I think I would agree to your second statement that if you see after the angiogram and then you feel that it's a high risk PCI because of high thrombus load, or you anticipate a slow flow or no flow, you can consider, because the onset of action is 2 minutes. But if you have a very fast channeling of the STEMI, like in our center, the patient is on the table by 12 to 15 minutes, and then you have loaded these patients with the DAPT name and just loaded on the way to a hospital after taking an ECG. So about 7-8 minutes is downtime in the ER and ECG is done. Then you load in. So another 7-8 minutes the patient is on the table.
How often you have had accidents by that ultra fast strategy that you are saying? Within minutes the patient is cath lab, etc. With a loading dose of Ticagrelor, without vomiting, without cardiogenic shock, aspirin plus Ticagrelor. In 10 minutes the patient is in the cath lab. how often you have accidents which...
I would say about 10% of patients because there are type A lesions where you can finish an angioplasty within about 20 minutes or 25 minutes, and proximal lesions where you don't expect any complexity with the tracking. Sometimes you may do a direct stenting without a pre-dilatation or even a thrombus aspiration, so you will see a TB1 flow, so you know the lesion site. So you won't finish fast, and these are the situations that you take. But as I said, I would take that decision on the table after the angiogram is performed.
That's your question. What I'm doing may be off late, but I do it only in those patients who are not preloaded elsewhere, who comes in a short span of window period where we are taking up the patient early for an angioplasty, where I'm sure that there is no effective antiplatelet effect. Second thing is, we don't have any data of this drug on slow flow, no info post angioplasty.
That's not it.
There is no data, absolutely no data.
Most of the data
is all for pre-procedural. Pre-procedural, you have an excellent antiplatelet effect on board by doing the PCA. Not after the PCA, no info and all. There is no data. So we cannot extrapolate this into no info. And the third thing is, we were happy with aspirin once. We were happy with aspirin and clopidogrel once. We were happy with aspirin and prasugrel once. We were happy with aspirin and ticagrelor once. Then when we have this drug, and especially it is not that costly, not very expensive, not a problematic, but it is only 9,000, 12,000 rupees for this drug to be on board, where if it gives some benefit to prevent a stent thrombosis, that is catastrophic.
Were you ever unhappy with aspirin? You can go into my question. Were you ever unhappy? Did you have accidents, etc., to justify the universal use of this?
No, there is nothing to justify the universal. It's only a personal.
No, we are still, I think, this is a new drug, it's newer. Despite FDA approving it in 2017, still not many people are using it. I think we have to learn from day wise, and I personally feel if it does not increase the bleeding risk, you have at least mentally you're sure and psychologically you're sure that you have 100% platelet inhibition and there is no reason for resistance as you create. So I think personally, if you are just small 10 millimeters single stent, you may still not use it. But when using contemplating a bifurcation, long CTO, where you think higher chance of stent thrombosis, there's always a reason that you should have this loading followed by some infusion. Of course, you can change, or you have to change it over to this. Very important advantage is bypass surgery bridging. If you have done it, if you have failed, for example, a CTO, or you have some complication during PCI, you want to go for surgery, and the surgeon would not take it. So that's a big advantage. I think in most of the complex PCI, if you are using this drug, this will be a very important utility in saving patients' life in future. I think we have to finish it off with too late. If there are no further questions or comments.
It's quite a common practice to get a referral note saying the patient is referred for semi-primary PCI and loading is given. So they would not indicate what is being given. So it's very common.
Because we are not
certain about loading. Don't
but loading of ticagrelor. But if you are doing it clopidogrel, you are still not too sure.
They will not indicate anything. The referral note will only say the patient has been loaded and referred.
That is why I think it's a more utility to use Cangrelor, because you're not too sure what it is. And to summarize the thing, Cangrelor is a new drug, intravenous antiplatelet, should be used in most of the PCIs. I personally feel not only the NAV, even the loaded patients can use it, especially if you are not doing a very simple angioplasty and there is no harm. And if you are going to fail in angioplasty and bypass surgery is contemplated, it is very useful modality because the surgeon can do it within few hours. They can operate because the effect of it is gone within 1 or 2 hours, and then of course the surgeon is very free to do it. Thank you very much for all this. I think it's too late. Now we have to finish with this.
Good evening, doctors. I am Ramanujan, Sales